Well, thank you very much, Dr. Dalal, and thank you to the previous speakers and Chair, Your Excellency, and all attendees. I'm greatly honoured to have the opportunity to chair the second session of this ethical symposium. Our next three speakers will focus on communication skills needed for telemedicine, the hot area of prescribing medicines through telemedicine, and providing security of patient records during all discussions and transactions, if we call it that, in telemedicine. Our first speaker in this session is Dr. Dalal Alromaihi, who obtained her medical degree with honours from the Arabian Gulf University here in Bahrain in 2004. She completed her residency in internal medicine in 2009 at Henry Ford Health System Wayne State University in Detroit, Michigan, after which she spent a year teaching internal medicine to medical residents as a chief medical resident. She then completed her fellowship in diabetes, endocrinology, and metabolism, also at Henry Ford Health System Wayne State University in Detroit. She has American board certification in internal medicine and diabetes, endocrinology, and metabolism. She practiced as a consultant endocrinologist at Yuma Regional Medical Center in Arizona, USA, and she moved back to Bahrain in 2014, joining KHUH as a consultant endocrinologist and program director of Saudi Board Internal Medicine Residency Program. She is a serving member and senior lecturer at the Royal College of Surgeons of Ireland in Bahrain, and was awarded the Best Senior Clinical Lecturer Award in 2016 for her teaching. Dr. Alromaihi has a passion for medical education, both at undergraduate and postgraduate levels, and has conducted several workshops for medical students and primary care physicians, alongside with a series of talks targeting patient education to the public, a very important aspect of all our efforts to educate. She was awarded a Guinness Book Record Award and Prize in November of 2017 for organizing the world's largest diabetes awareness session or lesson. She's a member of the American Diabetes Association and the American Association of Clinical Endocrinology and the American Endocrine Society and the Bahrain Diabetes Society. She's a member of multiple committees in the hospital and at national level. And it is a great pleasure to ask her to deliver her talk titled Communication Skills Needed for Telemedicine. Dr. Dalal.
Thank you so much. I just want to make sure my mic is on. Yes, it is. Thank you so much, Prof. Corbally, for your kind introduction. I have nothing to disclose in relation to this talk. So as you've heard from previous speakers, there are several advantages to telemedicine, from convenience, access to care, especially in the pandemic now, and cost. But according to all societies concerned with the assurance of high standard of telemedicine, it should always follow the same standards as face-to-face care, including adherence to professional guidelines, appropriate diagnostic testing, and treatment. Communication skills is highly needed. If we go through allegations or lawsuits or complaints, we will find that a big gap is communication. So if we improve communication with patients, we will reduce our risk, but most importantly, we'll provide proper care and highly appreciated care to our patients. So during my talk today, we will dissect through the anatomy of a telephone consultation. We'll highlight the needed communication skills, speak about how you could improve or enhance your practice if you have a practice that's running on telemedicine, how you could evaluate your services, and we will touch up on documentation because it's an important part of anything we do, and also share with you the KHUH experience. So I took an online course to learn about telemedicine because it's something new to us. And I learned that for a phone call, there's an anatomy, and there are 4 main components that we go through. First, the greeting, your verbal handshake with the patient, where you start the conversation and you establish rapport. Then there's obtaining the relevant information, then assessing the problem, and finally, closure, where you give the advice and the needed follow-up. So we'll go through them one by one and give you a few tips on how to improve each one of them. So the greeting, or your verbal handshake, is very important and has to have specific components for you to succeed in a successful tele conversation with a patient. First, you will verify the patient name. And I'm telling you from experience, I've had made mistakes before where I spoke to a patient and I say, you're Mohammed, you're Mohammed, you're Mohammed, and he's not the right Mohammed. So just going by your Mohammed is not enough. You'll need to verify your patient, as we know, by at least 2 identifiers. You will want to identify the hospital you're calling from or the clinic and the service you're calling from. Identify yourself by name and position and offer the service that you're providing. So here's an example. And in my clinic, this is where I run my telemedicine. I invested in one of these little things. I feel like I'm in a call center, but it helps. Hello, is this Mr. Adil? Good morning. Mr. Adil, this is Dr. Dalal Arromaihi, consultant endocrinologist from Endocrine Clinic at King Hamad University Hospital. I'm calling you today to conduct your scheduled visit by phone. Is this a good time to talk? What's your CPR number? This is typically how I would start. Scripted, yes. Professional, I think so, but I do it every time. And I have failed doing it when I do it differently. For example, if I just call a patient and say, I'm just calling to check on your lab results, or give you your lab results, or I'm calling to check on your diabetes, I find that the person on the second or the other part of the phone does not perceive that as a visit. So I make sure I state it as such. This is your visit over the phone. And here they regard it highly as a visit, a full visit. You want a tip? Record yourself and hear how you sound if people are talking to you. It will help you improve your skills better. And always use kind words, expressive tone, and empathetic. People hate it when you're like, yeah, okay, yes. They don't get that warmth. And you're on the phone with a stranger maybe who has not seen you before. So that gentle touch of a patient to or a doctor to a patient's hand or shoulder that we no longer get, we can deliver it by our voice. When you're obtaining information, remember that telehealth is health. Teleconsultation is a full consultation. I've had patients doubting the service. When I first call them, they say, I'm a new visit. How come you would help me over the phone? Luckily, with my specialty, I can manage to get a lot of the information I need by proper history and looking at investigations on labs, and they are impressed at the end that they were helped sufficiently. So it's still health. You'll need to take time. You'll need to take your full information. You will mix it between how you were trained in medical school and nursing school, mixed of open and closed-ended question. You want to be carefully listening, rephrasing what they've said, and sometimes you need to be assertive towards the end because some people might take a longer time and chit-chat about how the COVID pandemic has affected their life, etc., and the conversation can take longer. It's helpful to give heads up to patients even before the visit. If you have like an assistant who does a phone call before the call to see if they want the option of a video call or a telephone encounter. Like at King Hamad University Hospital, each one of our subspecialty clinics has a smartphone that can be used for a video call. But not everybody uses that option, but we should when patients do request that. And a lot of my colleagues do preparation before the clinic, a whole day before they go through the list and prepare. Nursing pre-assessment is extremely helpful, and especially if we need to have some data shared before the visit. For example, in my world of diabetes, we share sometimes information from downloads from patients' insulin pumps or their continuous glucose monitors, and that can be done a day in advance or a few hours in advance. In your assessment, here's what you're asking yourself. Do I know what's going on? Do I have a diagnosis, or at least I'm suspecting something? And are there any red flags? And that's very, very important. If you have that gut feeling that something is wrong, maybe something is wrong. And although it's the pandemic, we can still see patients face to face, and you might want to direct them to come and see you or see somebody else. And here's where you will think of how soon I need to see them again. Do I need to send them to the ER now and call my team leader there? And is this by any means an appropriate patient for telephone consultation? Maybe they're talking about dysphagia with a goiter. Maybe I want to see them in the clinic, and you can do that. So in closure, it's when you have the outcome of the call. You might have one of these options. You might have concluded with the diagnosis, you prescribe the medications, you follow up with your patient. You might have a suspected diagnosis, and this is where we have our soon scheduled appointments. We might send for urgent labs and imaging, etc., and have the patient be called in a week or 2 weeks or come in person. Or this is a high alert patient that you will refer urgently to the ER or another service. And we also have at King Hamad University Hospital, and I'm sure elsewhere as well, home care visits that can be arranged. So we have a full nursing team, a mobile unit that can go to the patient's home and do specific tasks there as we direct them. It helps at the end to summarize your conclusions with the patient, to say, okay, so today we have talked about this and that. We concluded, for example, your diabetes is controlled and we will continue your medications, or it's uncontrolled and we will adjust this and that. And I usually ask them to grab a piece of paper and write down as I give them the instructions, because I'm dealing with critical medications and insulin dosages, etc., and I want it written down. And I ask them to tell me what I just told them at the end. And we call that teach back technique, to make sure that my messages were conveyed properly. It helps to send that to them in writing if you can. If you can, send it by email, or if you can send it as an SMS or a WhatsApp message. And we have set up in our endocrine clinic and other subspecialties in the hospital, as I said, smartphones with WhatsApp business on it, and we can communicate such information to patients. And I find it crucial that at the end, we always give them a callback number. Put yourself in the shoes of that patient who's afraid to come to the facility because they're worried about COVID, and they need you because they ran out of medicine, or they've had an adverse effect, or they're not sure what to do. And I typically give them the phone numbers they need to schedule for a radiology, for another clinic. And again, we hand them out these WhatsApp numbers so they can call us through business hours. And we always give red flags, signs and symptoms to take them to the ER. So these are the components of a telephone consultation, and we've been through them all. And to enhance your practice, if your practice has telemedicine in it, it's important that you govern all that work with policies and procedures to direct who can answer what. Is a PCA able to say this or that? Is the nurse responsibility that or the other? It's important that we have policies and procedures. And you need staff training and orientation. I remember we started this in March 16, and we started in the endocrine clinic as a pilot, and we grouped the staff, we oriented everybody because we wanted the right message to reach the patients before the call. You also want to give directions to patients. This can be done electronically, or it can be done as a phone call, where people are given heads up. When the doctor calls you, this is what's expected, this is what will happen. And it saves time when we call them, that they're oriented to the service and that they regard it as a full consultation rather than they just called me from the hospital. No, that was a visit. That was a full formal visit. And periodically you want to evaluate how your staff are doing. You might, if you're in a supervisor or a senior position, go do a sit-down session with all of them and give them feedback on what they've done well or what can be improved. So a lot of things can be used as teaching tools for your staff, like role-playing, like critiquing live videos or group discussions. And one of the tips I've learned, but I haven't done it, and I don't think I will do it because I will be busted, is to call your own office. Call and pretend you're a patient. They do that elsewhere. Even I remember when I was a trainee, they had, I forgot what they called them. They're fake patients. They come here to just assess the quality of care that you are performing. We could do that over the phone as well. And any complaints you get, because you might get complaints, this is still reality of life, address it promptly and timely with your staff. I haven't heard of this in Bahrain, but I anticipate if telemedicine continues, we will start seeing such services. There are services called after-hour call centers, and these are outsourced companies usually, where you will have people receiving calls after hours during holidays and weekends, and triaging when to call the on-call doctors or nurses. If you're in the business of healthcare, this might be a gap in the market that you could develop. But after-hour call centers are something to look into if we sustain telemedicine in our practice. So in the last 2 minutes or 3 minutes, I'll just highlight a little bit of the importance of documentation and give you the KHUH experience. What do you document? As Dr. Lina said earlier, you have to have some recording of those encounters. You will need to put the identifiers, the phone number, relationship of the caller that you've contacted, what phone number you have reached, the purpose of the call, the chief complaint. And maybe we'll hear about it more through Dr. Mohammed Hilal's talk, but they have, because we are using electronic record, a lot of that is pre-populated, we have a separate window for a telephone consultation that has been very, very handy. Also, what you want to highlight in your documentation, if your advice was accepted or rejected by the patient, because you might direct someone to go to the ER and they tell you directly on the phone, I'm not going. You will, of course, try to convince them, but document if they have any refusal. And maybe these patients, you want to follow on them just for their safety sooner. And if you've given them even over-the-counter recommendations or what to do at home, self-remedies, you want to document all of that. I say that because in the third session, you'll hear about allegations or lawsuits, and all of that will come very handy. As I said, KHUH adapted telemedicine since March 16. And we have published our experience in the endocrine clinic in diabetes research and clinical practice, at least the first 4 weeks of what we've done. We called our publication or article, Sustainable Diabetes Care Services During COVID-19 Pandemic. We find it crucial that patients with chronic diseases get the care they need, especially during this pandemic. The worst thing for somebody with diabetes, for example, is to have poor control, and then they are at risk of the complications. And I know that this was not something easy to accomplish, as I've heard from colleagues from other countries that they couldn't because they didn't have the IT support to do that, or the resilience of the staff, or their staff were bombarded by COVID-19 patients that they couldn't. So I wanted to publish our experience, and I wanted to share what are the lessons learned. So if you look at here, this is the number of encounters we've had over the first 4 weeks. So these are 20-day visits over a month. And we have serviced 1,972 patients. 70% of them we reached over the phone, 13% were for medication refill. So you could say that 83% were served without being actually seen. Only 13% of patients came in person. So in our busy endocrine clinic, on average, we see 99 patients per day, or serve 99 patients per day. One of the things that I have thought about when we started telemedicine, that I might need less staff, so I can allocate the staff to COVID units, etc. But I was wrong, because patients unreached were only 4%. Back in the days when we had patients come to face-to-face visits, we had 20 or 30% no-show rates. So your load is a little less, but now your load is a lot more, and people do take time over the phone. So staffing needs won't go down. That lesson I learned. And the other thing we learned is that a lot of people at the beginning were insisting to come in person. They were not trusting the service, not sure what this was. As we kept going, as they knew more about it, the number of people insisting to come in as face-to-face declined. And we learned that you could adapt to a telemedicine service rather quickly. What are we doing else at KHUH? We are now studying with the quality department. Major Mona Hassan is helping us to study the patient satisfaction with the telemedicine services throughout the whole subspecialties in internal medicine. And we are starting even to bill some patients. If they are choosing to do these services by the phone, we can bill them. It's a service that's effective and available. We continue our education. You've heard from my introduction, I'm very passionate about patients' education. So we do have a diabetes education class that's ongoing, and it's actually lively and interactive because they used to come to us. Now we go to their living room on Zoom and be with them. And soon, inshallah, we will launch our first self-assessment and self-referral program for patients with diabetic foot problems. So I will conclude with that, and I still have my emails listed in case we don't get to it to the Q&A and you want to reach out to me. I welcome all your questions. Thank you so much.
A wonderful presentation, Dr. Dalal. Thank you very much indeed. Our next presenter is Miss Arwa Abouzaid, who's pharmacist and inspector at the National Health Regulatory Authority in Bahrain. She holds a bachelor degree in pharmacy from the University of Jordan, and she held previous positions as pharmacist in the Cardiac Center in Bahrain Defense Hospital. And today, she will talk to us about prescribing medications through telemedicine. Ms. Arwa.
Hello. Hi. So, how are you all? Today I'm gonna be talking about prescribing medications and the ethical matters in prescribing them through the telemedicine. Let's see if you have. Is it clear? Is everything clear? Okay. So let's start. Okay. First, I would like to recall some of the benefits of the telemedicine. I believe most of them were actually mentioned by Dr. Lina before, but let's recall some of them. And first comes the COVID-19 that we're actually going through, all of us. So COVID-19 came over here, and this is where telemedicine has proven its status in Bahrain strongly. So it's here, the telemedicine is here actually to prevent the transmission of of any infectious disease. So this reduces the risk on both the healthcare providers and the patients. It's again, it reduces the inconvenience, the time and effort to the family and the caregivers of the patients, especially the elderlies and the youngers. And it's very important in the case where there is no need actually for the patient to be in person contact, in direct contact with the doctor. Now, what do we actually need to prescribe a medicine through the telemedicine? Now, what's needed for the prescription is the same as the in-person consultation, the traditional way, a licensed physician. But the licensed physicians do actually have to keep in mind that they should be sure with the information they have gathered enough and relevant information about the patient and his condition, so that we can actually avoid any misdiagnosis. And in case the doctor is just not sure about what he has, then he can ask for an in-person consultation. As for the types of medicines that can be used in the telemedicine, we in the PPR department in NHRA, we have 3 lists, and those are the P list, the POM list, and the prohibited list, and those are to be discussed in the next slides. To start with, we'll go with the P list, and that is the pharmacy list. The pharmacy list, also called as the OTC list, over the counter. Now, the medicines on this list are actually very safe. They're normally dispensed without a prescription on the usual basis. They're very, very safe, as I have said, that they can be prescribed via any mode of consultation, whether it's a video or an audio, first consultation, or even a follow-up. The medicines on this list are actually different from the ones that are on the general sale, and those can be found in the supermarkets, and that list is actually on the website, and you can find it actually on the NHRA website. We have 2 types of medicines on that list, and those are the ones used in the common conditions and the ones used to be considered necessary during the public health emergencies. Now, as for the ones considered necessary during the public health emergencies, are normally announced by the government in these situations. For example, let's say the malaria, when they announced the chloroquine for it. When it comes to the medicines used in the common conditions, we have the antipyretics, for example, the paracetamol. We have the cough lozenges, like the cough supplements, not syrups, not medications. And we have the supplements, the ORS packets, and so on. As for the next list, we have the POM list, and that is the prescription-only medicine. As the name says, this list consists of the medicines that cannot be dispensed without a prescription. Yet the medicines on this list are considered to be relatively safe, that to be actually prescribed on either the first consultation or the follow-up. Some of the examples on these medicines are actually the ones used on the skin ailments, the clotrimazole, for example, benzyl benzoate. We have the local ear drops, the ones used for earwax, for example, eye drops, cefirixime. We have the medications used for the hypertension, diabetic, asthma, antibiotics, and cough syrups. When it comes to the follow-up in this case, again, I insist it's up to the doctor to decide whether he needs an in-person consultation or he's just sufficient with what he have. For example, either it's an add-on or a refill. Whenever the patient is there and the doctor decides that the condition is stable and he's just going to go on with the refill, then it's just on the regular refill status. But when the doctor decides, for example, that the patient needs more tests, or he decides that he needs an in-person consultation to add another medication, that comes to the doctor and the patient's, of course, comfortability. Next, we're going to talk about the prohibited list, and that's the last list we're going to be talking about today. And as for the prohibited list, this list actually cannot be used to be prescribed via the telemedicine. This list consists of the controlled and semi-controlled medicines, the narcotics, psychotropics, precursors, and we have the anti-cancer medications. Why is it not prescribed? Well, we all know that these medicines are actually dangerous. They have really high potential of abuse, and they do harm society if used improperly. We have witnessed a couple of incidences lately here, either in Bahrain or even outside the country, whether it's for the semi-controlled or the controlled medications. Now, we do know that as per the law, the use or the dispense of these medicines do actually require the original prescriptions, whether it's the pink one for the controlled or the original regular ones for the semi-controlled. We do also understand that for some doctors, the use and the prescription of these medicines is done on regular basis, for example, the orthopedics or the neurologists. But as I said, it's per the law, we're not allowed to transfer them into an e-prescription. So the best thing to do is do the teleconsultation as it's done, but we can work on handling the prescription to the patient later on by hand. Now, let's talk about what should actually exist in a prescription to make it authentic. Now, what should be there, this is just a sample, is the name of the doctor, the physician, the name of his clinic or the hospital, the address of the hospital, the date, the specialty of the doctor, of course, the patient's name and contact details, the CPR or the ID, and the most important part of it is the signature and his stamp. Now, as in for Bahrain, in Bahrain regulations, there is no certain messaging platform for the prescriptions to be delivered to the patient. It's always up to the doctor or the hospital to either send the prescription or the e-prescription to the patient, whether a copy of it, a scanned copy, or like a digital copy of it. Whether by mail or any messaging platform, it's always up to the doctor and whatever is comfortable to the doctor and the patient or the hospital. Well, I believe that's it for me. This is for the prescriptions and how to prescribe them and the ethical matters for them. I have attached a couple of the references, which is the procedure actually, and can be found on the website. And that's it. Thank you.
Thank you very much, Ms. Arwa. It was an excellent presentation. I'd like to move finally to our last speaker of this session, who is Dr. Mohammed Helal. Dr. Mohammed Helal has had a very interesting career, I might say. He graduated, he trained as vascular surgery resident in Cairo and started work around that time with an interest in software development for IBM. He holds a bachelor degree of medicine and surgery with honors from 2001 from Cairo University School of Medicine. He topped his class of a postgraduate diploma in software engineering and information technology in 2004 from the Information Technology Institute of Cairo, one of the most respected professional institutes in the field of software engineering. He has moved from product development software labs to core government information systems and services for the Kingdom of Bahrain, including government civil registration system, directorate of traffic, National Passport and Residency Agency, and many projects for the Prime Minister's Court and parliamentary and other areas. He joined KHUH in 2015, and in a very extremely busy and productive 5 years, he has been involved in the design and of the HOPE system that we use so well and love so dearly, and continues to lead and manage and develop that system. This healthcare operational environment is a modern, comprehensive, and rapidly evolving electronic medical record system, which provides ease of access for doctors, nurses to healthcare records. HOPE is currently powering the operations of KHUH as well as Bahrain Oncology Center. In my own mind, I think it goes from better to best at all times. He has, his dearest achievement is not only working at KHUH and BOC, but he has been successfully deployed at extremely prestigious private healthcare facilities in the Kingdom of Bahrain, representing the KHUH establishment. It's my great pleasure to invite Dr. Mohamed Helal to talk to us today about providing secure patient electronic records in telemedicine. Dr. Helal.
Good morning, everybody. It's a pleasure to be here. And it's always a pleasure to be associated with the prestigious panelists that we have today. The talk so far has been extremely interesting, and the topic that we are discussing today is very close and very dear to me. I hope that I will be shedding some light on the concepts of telemedicine and security and the application of EMRs in the modern healthcare facilities. So this is my agenda for today. I will be starting to define what is security, because security means different things to different people. Everybody describes security a little bit differently. I aim to provide a comprehensive overview of that. And then knowing security, there's always the concept of threats and cyber threats. It's very important to understand what these are and what are the possible victors and how to protect your patients, yourself, and your practice from such threats. Then we go into what is telemedicine, what is the difference between telemedicine and telehealth, and what is the role of EMR in both, and how important and how growing the EMR has been in the development of telemedicine and telehealth, both on premises and on the distance or remote practices. I will just share a few very high-level description of what are the international standards around security and safety, when especially it comes to electronic medical records and medical practices. And then I will go to a very crucial topic when it comes to cybersecurity, that is trust. And I'm not saying that in a rhetorical term. Trust and computer science represents something that is very formal, and computational trust is a basis of so many aspects of the practice of information technology and software engineering. Then we go to the topic that usually gets the most of the debates, the cost of security. It's often placed that we see people talk about the implications of having elevated levels of security. I will argue how important that is and what kind of trade-offs are there involved in that practice. And then I will go into the Bahrain and telemedicine practices and how far are we going and what are the recent advances and how come COVID-19 in specific has helped leapfrog or enhance the performance and the uptake of telemedicine and its acceptance. And then we will conclude by discussing the challenges and opportunities related to the topics. So starting with the title of the presentation, security and EMR and telemedicine. So first off, security. Security, again, is whenever people talk about security, they only concern themselves or focus on the concept of confidentiality. Privacy of patient information, how secure does the patient records are kept, and how limited access, who are authorized to access the patient files, what kind of audit trails, what kind of protection that the system provide to access the patient file, what kind of logs are being kept. If, for example, a change in the medical records has happened and we need to investigate whether that change was warranted, what kind of implications did it have, what kind of impact did it have on the patient. So confidentiality is definitely one of the core principles of information security. By the way, we refer to this as the CIA of information security, not the CIA that you're thinking of. This is the confidentiality, integrity, and availability. So they are very complementary, they're very comprehensive in their existence, and they are dependent on each other. So confidentiality, as we described it, and then the integrity. So integrity refers to the fact that the medical records generated or consumed by the healthcare providers are in a very practical and verifiable way are being kept safe, and they are being kept as a whole in their original form, and no tampering or modifications, unwarranted modifications can happen to them. So the integrity of the records are extremely important because time is always a fun factor when it comes to correctness of the records. So whenever you see a patient, for example, or provide a health service to a patient, documentation and the time stamping of the documentation that you enter is extremely important. There are dependencies, people around you in the clinic practice, in the healthcare setting, they often depend on the information that they have consumed from the system. So the fact that some information might change over time directly affects the integrity of the patient record and the integrity of the care and the quality of care provided to the patient. Last but absolutely not least is the availability. So availability is quite important. A system that is very secure, but oftentimes inaccessible is definitely not a good system. A system that is confined to a very limited scope of utilization is also not a very good system. So there's always a balance that we need to strike between security and availability and accessibility of the system inside the hospital or the clinical setting, the healthcare facility, and outside as well. Now, knowing your enemy. This is the reality of the cyber threats. I will not bore you with the technical details, but I'll have to go through them very quickly. So it's very important to understand that motives, people when they do attack healthcare facilities, they usually have motives. Motives can vary. They can be to make a political stance, to explore certain confidential details about a political figure, for example. But oftentimes, in even the most recent years, we have seen that this has been taking the back seat. The most common way of motives for security threats has been theft and profiteering from exploitation of information stored in the medical records, either denial of service and whatnot. But also, there's always the element of vandalism. Some people just like to see the world burn, if you know the quote from the movie, that they just want to see bad things happen to good people, or they don't simply care, they want to express their own tech savviness, gain dark web credits, for example. And then I just want to touch base on the incidents. So this is by no means limited to Bahrain or the Middle East. Of course, we've all heard about the international incidents, and if you follow the cybersecurity journals, you'll see that this keeps on happening. And information related to healthcare facility is extremely, extremely valuable. The argument is that your medical records on the dark web in a country that healthcare facilities are very expensive is probably more expensive than your credit card and your personal information. But let's not forget what happened in the year 2019. There has been several well-coordinated, partly successful cyber attacks on very large facilities of Bahrain. Industrial, healthcare, and whatnot. So what is the impact of the threats? Sometimes the impact can be simply as information leak, as we described. Sometimes it's about defacement, making a joke about the quality of a system, exposing flaws within a given system. But usually the serious ones are related to outages, causing outages, making the system unavailable to provide the healthcare services, what we refer to as a denial of service. Now, the last point is about the culprits, and the most obvious ones are probably the least important for our discussion. The most obvious ones are the hackers or the attackers, as you've seen them in the movies, and the mental image of what they do. But more commonly than not, it's usually an inside job. Most commonly than not, somebody on the inside of the healthcare facility is leaking information and exposing patient data, either unknowingly or knowingly, for an innocent reason. He's trying to help somebody, he's trying to send information to a neighbor or a friend, but sometimes that is not the case. Sometimes they do that knowingly to what they do, and they also might profit from the process. So it's very important to identify potential cases and seeing errant behaviors when they happen around you, and be able to vet them and report them if you must. The last point, which is, again, we'll talk about very soon, the innocent insiders. So we all have seen this, which is the bring your own device kind of thing. We all use our mobile phones within our work, within our facilities. I like to replace the word device with the word malware, because if you are not, as a healthcare professional, as tech savvy, careful, proficient, and making sure, careful about the quality of the usage of the device that you're carrying, be that a laptop, a mobile phone, or a tablet, these are the devices that pose an ever-growing risk of attacks onto the inside, because you're typically not knowing what kind of threat is involved. You are connected to a privileged network within the organization. You're accessing patient file to the audit and the security team. You are a legitimate user. You're accessing legitimate patient care, and unknowingly you might be doing something that is harmful without knowing what kind of effect that might have. So the important point to take here is that you have to be extremely careful and extremely vigilant about what kind of devices do you bring into a privileged environment like a hospital environment. Of course, the trial to prevent people from connecting to the hospital networks by simply denying them access is futile. There are so many legitimate reasons. There is definitely a usability aspect to having mobile devices. In KHUH, we use mobile devices for dictation, for accessing medical files away from a computer. So it's always a good thing to have a progressive policy about this. It's always good to have a way that devices are being vetted and are being screened and are being whitelisted in a way that guarantees the security of the system. So on this slide, we talk about EMRs and EHRs and secure access. So the mental image that we all have is that within the confines of healthcare facility, the EMR and EHR, hospital information systems, despite the variations, are accessible in providing services to the healthcare providers. All of this is well and good, but as we have said in the previous slide, the healthcare provider might be using a device that hasn't been screened by the IT department. And so even though physically he's located within the hospital, that might pose a threat. But in the most common way of telemedicine, there's usually a secure connection to the patient. And we have seen the growth of these solutions and the growth of adoption of these solutions. We will get to the positive effect COVID has. And of course, we have the VPN connectivity, which is now paramount practice to allow the connectivity of doctors from halfway around the world on a plane into the medical facility and perform the jobs and duties in cases of emergency. So the physical location of the provider is now less important than it used to be. And of course, as we have seen, the patient themselves are being accessed, contacted through the system, whether it's a simple telephonic consultation or video conferencing. So there are definitely practical considerations to that. And we all see the explosion of wearables and smart devices that enable the patient biometrics and vital signs and whatnot into the medical file that has to be also vetted by the EHR and EMR in question. These are some of the standards that they're being around the healthcare security. So HIPAA, for example, is about confidentiality. IPSG, a standard of JCI. There are a set of guidelines published by the Health IT facility, government entity in the US about the SAFER guidelines. There is also a cybersecurity framework, not the CSF that you're thinking of, cybersecurity framework that describes the practice of ensuring the safety and security of the patients. Now, trust. Trust is a very computational word in the sense. How do you know which patient are you talking to? How do you identify the provider that is providing the service? What kind of records and what kind of assurances does the system of record ensure that the patient, the system is being accessed in a secure way? Can you trust the glucose monitor that is sending you the reading to the system? Can you trust the infusion pump that is administering medications into the patient? How about the authenticity and the reliability of that vial of vaccine? Well, trust is a very core principle, and IT luckily holds the solution to many of those challenges. So patient-controlled electronic health records allow the patient to control who has access to his file and whatnot. A multi-factor authentication, just like when you try to log into Facebook and you get a challenge that somebody's trying to log in. Secure socket layer, which is the green lock that you see that ensures that the conversation with the system that you're talking to is very secure. This is probably a very contentious point, which is we often see that discussion that, okay, so the more we make systems secure, the less convenient it becomes. So there's always a point of balance that at a certain point in time, the system is tolerably secure as well as also convenient to the use. The most important thing I would like to highlight here is that when it comes to security, it's very good to handle the whole topic of security very comprehensively. But when it comes to the practice, you have to be very value aware. You have to be threat based. You have to understand what kind of problems might happen from a certain use of the system. And of course, you have to be proactive. Now, Bahrain telehealth and telemedicine startups, we all have seen the significant value of the Be Aware Bahrain application that has been used in the COVID, since the start of the COVID dilemma. And we have seen a Sahati application that bridges the gap between the internal hospital systems, but we're also, the internal hospital systems and the patients, but we're also seeing the rise of the private ventures into providing telehealth facilities. I believe that COVID has been extremely significant in the way it changed the way we practice medicine and provide services. And I believe that it would help us leapfrog into putting the focus on the practices and making sure that we do have, there's enough emphasis and enough investment in providing such services. And of course, we cannot miss the readiness that is provided by the Supreme Council of Health from the Bahrain National Health Data Dictionary, the National Electronic Medical Record, the Drug Utilization Review, and the HECMA, which is the organization that is supposed to oversee the exchange of information between the healthcare facilities. Of course, the maturity of the infrastructure is now paramount, and we all now think of internet as a given, which was a couple of years ago was a challenge. A couple of years even back, it was even unthinkable. So I will not bore you with those details anymore because I believe our colleagues have touched base on them. So identification of a patient, treating the records very carefully, making sure that the patient is who he is, making sure that you identify them properly, making sure that you do the documentation properly, and make sure that you consume the information in a way that is respectful to the patient and his privacy, as well as provide information for other colleagues to be able to provide the level of care the patient expects. Telemetry is now booming, and we are now seeing the availability of commercial devices that will be able to bridge the gap between patients at their homes and in home care facilities, home care settings, and the electronic medical records. As I said, COVID has been, to me, a silver lining to the pandemic cloudy storm, because again, it has motivated people to invest more. Each and every private hospital in Bahrain now has some sort of telemedicine on its agenda, teleconsultation for that matter. And we have to accept that telehealth is actually now a practical reality. It's just that I don't think that the after COVID cloud storm goes away, that the telehealth wave will subside. I think that the change is here to stay, and we have learned a lot from the practice. And I think that now is better than ever to really invest and really participate actively in the development and fostering the successful implementation of telehealth and telemedicine. With that, I wish you the very safe practice for yourself and your patients. And please go ahead and change the world, make it a better place for your patients and for yourself. These are my contacts. Please feel free to contact me if you have any questions.
Thank you very much, Dr. Mohammed. That was a wonderful presentation. And I'd like to extend my congratulations to all three presenters for keeping on time and really excellent factual distribution. I have some questions, and I might ask people, participants, if you have a question, perhaps you put it on the Q&A section, and then we'll try and get it. But also, you can, all of your questions will be directed to the speakers in due course. So my first question would be to Dr. Dalal. And I just wonder, we have a very significant decline in attendance in the study period that you noticed. Was that due to, you think, an acceptance of the utility of telemedicine consultations, or was it due to perhaps concern over COVID-19 and people attending hospitals where they might be exposed?
Has to be a little bit of both. We did not look into the cause of that, but it was something we have noticed that their attendance declined. But until now, when we speak to patients, they do express that. They have fear of the hospital space. Although we reassure them that at KHUH, we don't have the COVID positive patients. They do go to designated facilities. We have all the precautions when you come. And this had a little bit compromised some of the care because some of them will refuse to even go get their blood test done or the radiology done. So in specific to our study, I can't conclude with certainty it's the service or the fear, but I would say it's a little bit of both.
Okay, thank you. And in terms of internal quality assurance and internal controls of quality, what do you think we should do to ensure on a regular basis that the way we conduct telemedicine consultations is appropriate at all times? Because is it possible that everyone needs to have a course or instruction on how to conduct a telemedicine interview? Or do you think that's something that can be learned on the job?
I feel obliged that we have to train and we have to evaluate periodically and give feedback. As I said, it's like with this COVID-19, we are relearning how to teach. We're relearning how to treat. It's like if you had a stroke and now you have to go through rehab and relearn the skills that you've known for years. So I feel obliged to look at the policies, look at the procedure, improve services. And luckily, KHUH is very flexible to change and adaptive. I should say that. With our IT and admin, etc., we can do a lot. Staff are receptive and ready to learn. And as I said, we're now evaluating patient satisfaction, and we will guide our training based on that outcome. The areas that we see most deficient would be the areas that we start with first.
Thank you. Ms. Arwa, could I ask you in terms of, can you unmute?
Sure.
Okay. In terms of streamlining efficiency for telemedicine prescriptions, do you think it would make sense to have designated pharmacies or health centers for distribution of healthcare of medicines, and the telemedicine consultant or doctor text, emails or faxes even that prescription to the health center or the pharmacy so the patient can collect it? So you have designated distribution points outside of hospitals. Would that not make the process more streamlined?
Probably. It would probably be easier for the patient. And again, it's we have to make sure that it's designed like the correct patient, the exact patient is actually delivering the correct prescription. Sure. Like this is the main thing we care about, so that it's not headed to some like different prescription. As I said, especially when it comes to the controlled and semi-controlled, when it comes to the prohibited list, this is the most concerned by other doctors, the most concerned area by other doctors, how to deal when it comes to this list. The most important part is that to deliver the exact and correct prescription to the designated patient. This is the most important part. So yeah, I do believe this is a great idea. It would be amazing.
Thank you. There are currently some questions lining up, but I have something to ask of Dr. Mohammed. I had a comment about the balance between access to safety and security of access to information and the practicality, but you've answered that. But where does that? Do you think that we should err more on the side of practicality, flexibility, or more on the side of security?
Well, it's a very good question, and I think that it's quite important that we be very pragmatic and very practical about answering it, because technically you can make a system that is so secure that nobody will ever be able to use it. But that's not the point of having an electronic system or record system in general. So striking the balance is usually a process. It's not a simple answer or a general principle that can be applied everywhere. The sensitivity of the medical records is, all the medical records are sensitive, all the medical records are confidential. There are usually hospital and house imperatives when it comes to the maintenance of records within the hospital or the healthcare facility that mandate certain levels of access and certain level of convenience or accessibility of old records. I always believe that it's a continuous feedback mechanism. You'll always go back and revise the decisions that you've taken previously based on the inputs from the current incidents or feedback from the end users. Sometimes they will ask for things to make their work easier, but it's potentially less secure. Sometimes they come up with very innovative ideas that will actually make the system more secure, as well as actually easier for them to use, more convenient for them to use. So my answer would be it's a continuous process. It's a continuous feedback process that should always be encouraged.
Well, do you think, therefore, that patients should be able to access their file?
I will go one step further than that. I will say that I'm a fan of patient-controlled electronic health records. And I think that, again, the explosion of wearables and mobile technology and mHealth and things like that have finally provided the critical mass at which we can begin to see effective control of visibility of my own personal record, my own health record, and probably be the sole custodian of whether that particular doctor gets to see that part of my health records or not, depending on my judgment, which is something that people would argue that electronic health records have stripped the patients of their rights to control who has access to what and what gets shared and what not.
My personal opinion is that they should have access to their medical records, and I do think it would actually enhance the quality of such records.
Absolutely.
Going forward, I think it's something to be looked at. I might just look at the questions and answers, if that's okay. We might have a little bit of time. Take one or two. I'm an intensivist at BDF. My question is about relatives' visit to ICU as it's prohibited in the pandemic. Is there a way to provide a phone to patients to video call their loved ones, as most of the time they feel disconnected? They try to call the ICU reception, and most of the time the attending intensivist will be too busy to reply to the call for all the patient's relatives. I also noticed in other countries they provided robots with screens that can provide full picture of the patient's condition input. Anyone of the presenters wish to take this? Dr. Dalal?
We have tried this in a different way when we were trying different models for the inpatient rounds, especially to minimize exposure of our healthcare teams to patients in the wards in case somebody is then found to have COVID, that we have isolated the teams and not have everybody contact and have to be home. So one of the things we've tried is that we asked one of the doctors to be designated to this certain ward, and they go in with their phone on a video call with them and the patient, and the rest of the teams on the second part of that phone call. So it's like you have the robot, but we don't have robots, we send the doctors. Okay, so patient feels at ease because they don't think that there's a junior doctor coming to evaluate them and give them advice. They know the consultant is there. Similarly, this can be done in the ICU. I don't know why it couldn't be done. Maybe the larger screen so the patient can easily see them, they can see. It can be done. There is a huge room for innovation. Perhaps
for limited periods, etc. That question was from Dr. Khadija Hamad. So maybe just one more question if we have time. Are patients allowed to print prescriptions at home via a telemedicine platform and get it from pharmacy? Ms. Arwa.
Yeah, they are. As long as the prescription has all what it should have, actually the signature, the stamp, and all what was mentioned actually that the doctor and specialty, as long as the prescription is authentic, then yes, we can go ahead. We can proceed.
Okay, maybe just the last question from Dr. Maha Goroba. Are we expecting teleconsultation will continue after the corona outbreaks? And do you support that?
This sounds like a question for you, Prof. Korbeli.
Well, I think this, my own feeling is that every crisis is an opportunity waiting to happen, and that when one door closes, several more open. So this is a catalyst for change. It's a catalyst for much needed change. I think it offers the opportunity not only in access to records, but in the quality of the consultation, which will be recorded. So you have a way to feedback and improve the consultation process. There are limitations, as Dr. Jamal rightly pointed out, in terms of some specialties. Certainly in surgery, it may be difficult to offer consultation for new consultations, but in follow-up, it's enormous potential. So my answer would be yes, provided we put in the restrictions that Dr. Lena rightly alluded to and stated quite clearly. We have to be professional. We have to prevent abuse of confidentiality issues. We have to be practical in our access to information. And I think the patient must have access to the information at all times, their own unique information. So yes, I hope so. I very much hope so. So I think we can close this session, and I'd like to thank all the speakers for truly wonderful presentations. I hope that all the participants enjoyed it. If anyone has further questions, they can address them directly to the panel, to the speakers. Thank you very much.
Thank you so much. So we will be moving to a 1 minute maybe break while we move speakers from this session and bring others from session number 3. Thank you to all our speakers. Thank you, Professor Korbeli. And while they are doing that, I can show you a quick video on the education we do for diabetes at KHUH when we go and do it on Zoom. It's in Arabic, I think, but you can read it.
الدكتورة دلال أحمد الرميحي